And then that way, if you miss something I say, because I don't say it loud enough, then you can always go back and watch it later. So, but what I wanted to do, oh my word, sorry. Okay, what I wanted to do is kind of have the first part a little bit of a Q&A. I'm gonna, first of all, about the quiz, what I'm going to do is I'm going to take all of the questions and I'm going to put them onto Moodle, and I'm going to have it be a take-home quiz. So I'll load up all the questions onto Moodle after class, and then I'll send you out an email saying that it's open. And then it'll just be timed. So it's essentially going to be like, you know, open book like the other one, but it's timed. So if you don't know the material a little bit, you know, you'd have to race to find the answers. So I feel like it's sort of a fair switch off. So I'm going to do that with the quiz so that you can have some time, some material to sort of test yourself on, since the exam is coming up, even though I feel like we've barely had any class time. And then about the exam, because that would be next week. So what's happening with that one, it's going to cover what we talked about the first week. So that introduction to pharmacology. And then it's going to have this autonomic nervous system. And then it's going to have the thyroid and the diabetes. And it's about, the exam is broken up into about thirds. So like a third is the first week, and a third. There's only going to be, I think it's 40, it's either 42 or 44 questions. And what I'm going to do is I'm going to allow you to have a sheet of paper that you make your own notes on. So whatever content you just feel like you're struggling the most with, you can write on that sheet of paper that, you know, notes for yourself, and you can have it with you during the exam. And the reason I'm doing this is, I was going to do this even before this first couple weeks were such a debacle. And the reason is because we have guest speakers, and the cardiology guest speaker could only come in on that day. And so I love having the guest speakers. They're really knowledgeable, and I just didn't want to lose his presentation. So I'm having him come in the same day as the exam. So I'm trying to make the exam not so stressful. So I shortened it a little bit. You can have notes, one note sheet that you can write out notes. That also helps you study anyways, because you're writing stuff out. And so hopefully that will make you feel less stressed about taking the exam. I also wanted to put it out there. If I wanted to know if you guys would be willing or able, and I actually should do a poll. I'm going to create a poll right now really quick. See if I can even do that. I thought it would just let me do it. Okay, hold on. This is like flying by the seat of my pants. I don't know if this will work, but okay, hold on.
By 11, that's just a regular sheet of paper. I guess
so. Okay. So I'm asking you if you're willing to come in or start class like 10 minutes early next week, so that we can get going on the exam, so that you guys don't feel as crunched for time. So I'm just going to see if this works here. I don't know if yes, 8 by 11. So a piece of paper. Yeah, not a note card. I'm looking through your notes here. So just a sheet of paper, 8 by 11, one piece of paper, and then you can pre-write before your exam. So like the night before, you can write down the things that you're worried you'll forget. So you can write down and just fill up the paper with notes, however that will be helpful to you. And then I was going to say just one-sided because some people can write really small. So, and I think one side is, probably sufficient. It's not going to be heavy on like medication quizzing, like what is this medication for? And what's that? I think, it's more basic concepts that follow the outline of the PowerPoints really. And so sometimes I was talking with a few students on Tuesday, and they were asking about some of the stuff for the autonomic nervous system. And when we were talking, it's like, oh, this is actually like surface level. We're not getting super deep into this. You can go down many rabbit holes with these conversations because there's different things that are affected. Proteins come in, all sorts of things. It can get far more complicated than how we're learning it. So sometimes we go too far and we make it more complicated than it has to be. And so hopefully I can help with that too, if we do a little Q&A. Did you guys see the poll? Will you be having? You haven't seen the poll yet. So the top 20 drugs are not going to be necessarily on an exam specifically. However, in a way that it'll be like quiz on top 20 drugs. But what it will look like is, so let's say one of your top 20 drugs is metformin. And so on the PowerPoint, I highlighted it in red writing. So you may be tested on a top 20 drug in that respect. So it won't be like random top 20 drugs. It'll be a top 20 drug that was highlighted in a PowerPoint, also bringing it to your attention because the font will be red. And that's not to say that other drugs that we talk about wouldn't be on an exam, but they're going to be the really common drugs that you're going to see or that are highlighted in the PowerPoint. Does that answer that? Okay. I wanted to see where I could do this poll thingy here. Activated. I don't know. Maybe I can't do it. Oh, launch. Okay. Oh my word. You guys can tell my brain's not, my question doesn't even make sense. Are you will to start? You know what I meant. Okay. It looks like, and if you're saying no because you can't get here earlier, then that's fine too. I understand that if you have a longer commute. I think so. This is how the timing will work out. If we start at 8:30, like on the dot, we have to be done with the exam. And since it's not 50 questions, that's also why I took away some of the questions. We're going to have to be done by 9:20 because the speaker comes in at 9:20 and you might want a bathroom break. So that gives you 50 minutes to take the exam. But if we come in 10 minutes early, and I'm hoping that some people take exams fast, some people take them slower. So I'm hoping that, the majority of people get done and they'll be able to take a bathroom break before our speaker. And then for the people who take a little bit longer on the exam, they'll at least have enough time to do it. And you can still take a break. Even if the speaker starts talking, you can go out and take a, I mean, that's fine. But at least not everybody will be out on break at the same time once he starts. So, so maybe what I'll just do, if you can, if you said no, if you can just shoot me an email as to why, if that's like you just can't get to class, and it's totally fine. I think I may, what I might do is those that show up maybe will start the exam. Well, no, that could be disrupting, but so let's just wait. I won't make a decision yet. Just if those people who voted no could just let me know why, and then maybe we can see if I can work something out. The earlier we start the exam, the better. But I want it to be fair for everyone, and I don't want it to disrupt anyone. Okay, so we'll just think about that a little bit more. Okay. All right, so at this point, I want to see, I'm going to show you guys, I'm going to stop sharing this. Well, actually, let me just see if there's questions. Let's start with questions on the autonomic nervous system. Can you guys either type into the chat, or if you want somebody to, if the majority of you are in class, if someone wants to go up front and just field questions, or however it works out best for you guys, you can type it into the chat, or go up closer to the computer and ask questions. But are there any parts of this that are just really fuzzy or confusing? And if I don't get questions, I'm gonna just kind of jump into a few areas that I think typically people with this, okay, the sympathetic. I'll jump into a couple of areas that I think people struggle with, or at least for questions from what I've heard so far. So one of the biggest things, okay, let's see. Oh, here come all the questions. Okay, so as far as the receptors, what they do and what they don't do, even though this is really interesting mechanisms, it's really important to not get too worried about things that aren't presented to you. So one of the biggest things to know are that some drugs, so when we're talking about drugs, some drugs will have a stronger affinity to one receptor over the other. So they may work on more than one receptor. So like one of the questions is, do the alpha receptors close up certain parts of the body? So when a receptor is being activated by a drug, there may be a different receptor that's more activated by that drug. And so drugs can work on different receptors, but there's going to be one that has a stronger affinity for it. So that's why, and the more we talk about each section, the more we talk about like asthma medications or nasal decongestants or, different things like that, heart medications, we'll refer back to these receptors and talk about how they work on the different receptors. So for example, one of the things that was confusing about the alpha receptors is the alpha 1 receptor, they work on the vasoconstriction, and as a result, they make the blood pressure go up. So they're working on smooth muscle. And so then we were looking at the alpha 2, and it almost seemed like it was doing the opposite. When if it's an agonist, you think it's going to increase something, but it's like it shuts down glucose and things like that. So there's a lot of different drugs that alpha 2s work on, and there's some drugs that work on the central nervous system that have alpha 2 receptors. But for our purposes, all we have to really think about is we can maybe think of alpha 2 as maybe like a checks and balances, like instead of things, you know, or it's going to shut down, like maybe closer to what your question is, it's going to shut down areas that don't need, like all your peripheral blood supply. You know, you might not need all of that. If you get injured, you don't want to bleed out. And so your body does these things that are protective in one circumstance and then opens things up and gives you what you need for something else. You like for your mind to think clearly, for your lungs to get lots of oxygen, but maybe your peripheral blood supply is gonna shut off so that if you do get injured, you don't bleed, you know, you don't bleed or something, you know. So your body has all these mechanisms and checks and balances. And so that's when one of these systems is kind of raring to go, there's going to be some parts of the body that are going to be getting more of what it needs to support this system, and then other parts of the body that are going to not get as much of whatever it is, whether it's blood or oxygen or enzymes to make things, different functions happen. So it's just going to depend on what your body needs at that time. Okay. So the question is, what is another name for the adrenergic agonist? So if we look in the PowerPoint here, when we talk about the, it's back here. We want to think, when we're thinking, you want to kind of pair things together. So you want to pair adrenergic with the sympathetic nervous system, and then you want to pair the cholinergic with the parasympathetic nervous system. And so if you pair those phrases in your head, that will help you think, because some of these are kind of confusing, especially when you say adrenergic antagonist, adrenergic agonist. There's lots of A's and it's just like a tongue twister. But if you pair them in your head, so if you know that your sympathetic division are your adrenergic receptors, and then here it talks about the alpha and the beta, and then the agonist and the antagonist. So here, where is it? So here we go. So the sympathetic nervous system, adrenergic agonists. So another name for those would be the sympathomimetic drugs. So these are going to be your drugs that work on the adrenergic receptors, and they enhance their mechanism. So as a grouping of drugs, they're called sympathomimetic drugs. And so vice versa, if it's another name for adrenergic antagonist, something that's going to block those mechanisms, they're sympatholytic drugs. So those are different names for those. So the beta receptors can amp up other parts of the body. Yeah, and different areas of the body have different receptors. So like a lot of, you know, like we have a lot of the beta 2 receptors on our lungs. We have a lot of beta 1 receptors on our heart, or there's in the GI, there's alpha 2 receptors. I mean, there's just different areas of the body that tend to have more receptors. So that doesn't mean that there aren't all these receptors everywhere, but in general, you have certain areas where more receptors are, and they've pinpointed these because they can see what happens to the body, like when we get afraid and the different mechanisms that happen. And so they've pinpointed these and what they do, and then they make these drugs that work on those receptors. Okay, and for antagonists, so yeah, so adrenergic agonists are sympathomimetic drugs, and adrenergic antagonists are sympatholytic. So just what it says here in the parentheses. So that's what it means by what's another name. Is it always beta 2 that has a stronger affinity? Not necessarily. It can be, I mean, it just depends on the drug, because if you have a drug that has, a stronger affinity. So it's, like take local anesthetic, for example, or epinephrine in local anesthetic. Epinephrine works on beta receptors, and so you might get some reaction on the beta receptors when you give local anesthetic with epinephrine, but it has a stronger affinity toward the alpha-1 receptors. So in general, epinephrine is going to cause vasoconstriction. And it's gonna help to constrict the blood vessels, but people are gonna get like like a fluttery heart, their rapid heart rate for a minute, because it is working on all those receptors. It's just that it has and so the higher the dose, the more effect you're going to see on what has the stronger affinity. Okay. Well, we need to know each part of the body has which receptors. The biggest thing you just need to know is the smooth muscle, the alpha. So alpha-1, alpha-2 it's kind of a weird one. It's not so, it doesn't fit into so much. I mean, there's lots of interesting information about alpha-2. I was looking into it more yesterday because of questions that I had from students on Tuesday, and it works on a lot of medications that are more like for that have to do with anesthesia and recovering from general anesthesia there, but we're not really going into any of that. So in our class, the alpha-2 receptors are kind of just breezed over, sort of. But so alpha-1, beta-1, and beta-2. So knowing smooth muscle, so like your blood vessels for alpha-1, also blood vessels like in the nose and things like that, because it can be a decongestant. And then knowing beta-1 is the heart, and beta-2 are the lungs. But it also is good to just really pay attention to all those body parts that are highlighted in these diagrams here. These diagrams, and just thinking about what's stimulated and what's stimulated and then what's suppressed. And one of the biggest things that I'm realizing is not on this, and I think it's because we talk about it more when we actually get more into drugs, but one of the biggest things when we talk about drugs that are, sorry for jumping around, I'm going to go back to the cholinergic, the parasympathetic. So anticholinergic drugs, or anticholinergic, cholinergic antagonists. We talk about this a lot, because when you have the parasympathetic system in charge, basically, and you're feeling relaxed, you're resting and digesting, you have plenty of saliva, you have you're able to go to the bathroom, you're digesting your food, you're relaxed. But if you take anticholinergic medications, which there's several out there, there's a lot actually out there. If you take anticholinergic medications, there's something called, and you'll see this on your handout that's in, I'm going to share it in just a second. I'm going to go pull it up. But if you take these medications that are anticholinergic, so you can kind of think about it like anti-parasympathetic nervous system, it's doing the opposite. It's going to give you dry eyes. It's going to give you a dry mouth. It's going to make it so that your digestive system slows down and you can't go to the bathroom as easily. So there's a grouping of the way they describe it. They call it SLUD, and I'll show it to you. I'll pull it up, and it basically means like, you very little saliva, lacrimation. It's like dry eyes. Lacrimation is, watery eyes, and so no saliva, no eye moisture, and then I think urination and defecation. I think that's what the SLUD is. So it's like none of those things. And so that's something, and I don't know why it's not on my PowerPoint, other than maybe I just introduced it once we get into the medications, but I feel like it fits really well here. So I need to add that in, but it is on a handout. And so I'm gonna pull that up here in just I think it's there. Where is it? Where in the PowerPoint? Okay, let me stop sharing this for just a second, and I'm going to pull up the worksheet that I wanted to show you guys. So there's a couple flow sheets too that also kind of highlight the things that you really want to make sure you're. Oh, and I know that some people were asking questions about the flashcards and how to answer those, so we can talk about that too. Okay. So the first worksheet here, this one, so this is some of the stuff that you're going to want to think about when it comes to these these different mechanisms. So you want to be familiar with the heart and how the main receptor that we're focused on with the heart is beta 1. And then we're going to reflect back on these often when we come to the chapter on cardiac medications. We're going to come back to this. So it helps to kind of remind you and drive it home. But for each one of these, we wanted to talk about what it is that receptor kind of does when it's activated, and then what it does when it's suppressed. So like here, I just put beta 1 to remind myself the heart is beta 1, beta 2 for the lungs, and then this is smooth muscle or vasculature, and this is alpha 1 and some of beta 2 as well. And so then we want to know that alpha 1, if it's an alpha 1 agonist, it's activating the alpha 1 receptors, and it's going to constrict the smooth muscles or be a vasoconstrictor. So we can think of something like epinephrine in our local anesthetics. This is going to be working more on the alpha 1. And then alpha 1, if it's an antagonist or if it's blocking, then it could dilate or relax the smooth muscle. So it could be a vasodilator. I also had what did I have that written down? So some medical, so I have some other notes here. Oh, that's on the other side. I'll show you the other sheet in a second. Okay, and so then we have alpha 2 agonist and inhibits the amount of norepinephrine release. So norepinephrine is in your sympathetic, so it gets everything kind of like revved up and raring to go. But it kind of, if it's an alpha 2 agonist, it's going to, there's these little alpha 2 receptors on the, so on your neuron, your preganglionic neuron, as it's releasing all of its neurotransmitters, there's still some receptors on that side that will reuptake stuff and pick stuff up, like little cleaner, little vacuums, or they'll clean it up. And there's receptors that are alpha 2 receptors on the same side that releases the norepinephrine. It also picks it back up. So it kind of almost acts like a check and balance, I think, is the way I was sort of envisioning it. There's also a host of medications that we just don't really get into. So for alpha 2, you don't have to think too deeply. We don't really deal with it too much because it doesn't come into play so much with the heart and the lungs and the smooth muscle. An antagonist, or if it's being blocked, there's limited clinical use. So again, I think the agonist part of it is more like for these CNS, central nervous system medications that we don't really talk about in this class. Okay, so then we have the beta one. So we're over here at the heart. If it's an agonist, it's going to increase stroke volume or force. So it has to do with how hard your heart is pumping. So maybe people with heart failure, congestive heart failure, but it's going to increase the rate and the force of the heart. So increase heart rate and force. And then if it's an beta 1 antagonist, or it's blocking, then it's just doing the opposite. So a lot of times, if you can figure out the one, like you can figure out what it's the agonist part, then you can just kind of think about it in opposite. It's just going to do the opposite. If it's an antagonist, it's blocking it, so you're going to get less of that effect. And then, so beta, and then the beta 2 is going to, with the lungs, the beta 2 is going to open up the bronchioles. It's going to dilate the bronchioles. And so we have to be careful with if it's something is a non-selective beta blocker, because then it can do the opposite of that, which would be, constricting, which we don't want that. So a lot of times, if something is a beta drug, we want it to work on the heart, but we don't want it to have a negative effect on the lungs and breathing. And so, so then we start talking about non-selective or selective beta blockers, or different receptors. And we will touch on those as we get to those medications, but that's something that we have to think about. Okay, I'm going to stop sharing that, and then I'm going to, let me see if there's any. Oh yeah, the flow sheet. Yep, it was. So that's that thing that I was talking about, the anticholinergic side effects. That's on the flow sheet. And oh, I thought it was on this one, but no, it's just on the flow sheet. Yeah. Okay, and then I'm going to take this one down, and I'm going to pull up the other one. Now, these worksheet answers are open in Moodle, so you can go back and look at these, but this is the kind of information that you just want to be familiar with for the exam, and then for the quiz too. And the quiz, like I said, it's going to be kind of an open book, but it's timed, so you want to read through all of this and familiarize yourself with it as much as you can, so that you're not stumbling to try and find your answers when you take the quiz. Okay, I was just going to show you one more worksheet. And this is the way it's showing up is kind of weird. I don't have, I'm looking at it through Moodle, so I don't have the original pulled up. I just have it pulled up on Moodle, so it's kind of a little bit weird. But so these questions too, so they're just, a lot of times these are just asked in different ways, and so it's for your mind to think about them in different ways, but a lot of times it comes down to the same thing, knowing, where the alpha-1 receptors are predominantly and what their effects are on the body. That's the biggest takeaway. And then knowing the terms, like knowing that cholinergic, parasympathetic, the receptors, muscarinic and nicotinic, all of those are kind of in this category. And then knowing that in the other category, we have the sympathetic, the adrenergic, the alpha betas, and they're all in that category. And then also kind of having a nice understanding of, if it's parasympathetic, then it's going to be more, rest and digest, and then start to think about those body systems that are resting and which ones are more active during that. And then the same thing with the sympathetic, which body systems shut down. Generally, you don't have to know like mega crazy detail, but in general, and which ones are more activated. And it's super easy when you think about they use it all the time as like an example. When you think about running away from a tiger, it's like the classic example. You want to have your lungs full of air, you want your heart pumping, you want your brain sharp and alert, so all these things. You don't have to digest your food because you're trying to get away, so you can kind of break it down into these bigger sort of these bigger concepts instead of like the little ones. But then when it comes to the receptors, we do want to know when they're activated, like what blood vessels, if blood vessels are going to constrict or are they going to dilate, or, so that's, we do want to know that information. So what disorder would a medication that's a selective alpha-1 agonist, so it's on an alpha-1 receptor and it's an agonist, so it's going to elicit the activity of the receptor. So the drugs that are used to treat low blood pressure, so if somebody has low blood pressure, then they want to constrict, and if alpha-1 gets activated, it's vasoconstriction. So that's kind of the medical use for it. If somebody's blood pressure drops, they'll give them an alpha-1 agonist drug, and it will cause vasoconstriction. Also, they use it for nasal decongestion and ocular decongestion. And so then we just go down the line and try and answer these before you look at the worksheet answer sheet, but they're there for you too, to just kind of help you get those in your mind. And this is the same thing, how you'll do these flashcards. It's right, alpha-1, what body part does it work on? What happens if it's activated? So it'd just be alpha-1, smooth muscle, blood vessels. And then if it's activated, it's constricted. If it's not activated, if it's an agonist, then it's the opposite of constriction, it's dilation. And that's kind of how you can use all of them. One activated, the other one would be sort of the opposite of that. And then down here, you can see if a drug has anticholinergic side effects, what are those side effects? So there's that SLUD. So low salivation, lacrimation, urination, defecation. And so then here's some other ways of saying it. You can get xerostomia, which is the dry mouth, urinary retention, blurred vision because of the dry eyes, constipation, or tachycardia is another one too. They can get faster heart rate because in the parasympathetic, your heart rate would be slower. Okay. Okay, I'm going to stop sharing that. The thyroid, the thyroid lecture that I recorded is pretty short. Does anybody have any questions on thyroid at all? Okay. Okay, so I'm going to pull up, let's see, what time is it? We go till 10, right? Do you guys want to take a quick break? You want to take like 5 minutes? Or are you guys just kind of going as you need? Do you want me to just go through, start with the diabetes, and you can just get up and move about as you need to? I'm getting a few yeses. Okay, so obviously feel free to get up and use the restroom if you need to, and I'll just pull up, I'll share the diabetes PowerPoint and we'll just get into that. Oh, and I did also want to tell you too real quick, the blood glucose, I'm going to find a time early next week where we can all just meet in the classroom. It'll probably be like over lunch, and we can just meet in the classroom and practice. It's really important that you get a chance to practice it on somebody before you have a patient in your chair that you need to take blood glucose. It's easy. It's just nervous in the beginning because you're like, how do I make sure I do it the right way? But it's not difficult. And once you've done it on somebody, and some of you may have done it in the past anyways, it's not a big deal at all. It's very quick and easy, but it's much better if you get a chance to practice it before you do it in clinic. Also, we want to practice it because we don't want to waste the test strips. They're really expensive, and if you get an error if you don't do it just so. And so want to make sure that we get a chance to practice it. So I'm going to look at your schedule. I'll talk to Monica and see, and it might end up being over a lunch. It wouldn't take the whole lunch. It'd probably only take a half hour at, but just a heads up on that, because we were going to do that in class today. Okay, so let me get the diabetes pulled up here, and we're going to go over that. Can you guys see? Okay. Oh, I can actually see the screen. It looks like you can see it. Okay, good. All right. So I'm going to go through this a little bit quickly because I know we are a little short on time, and it's hard to sit there and just listen to somebody over the computer. I know the sound's not fabulous. Oh, wait, hold on. No, you do not need to hand in those worksheets. Those aren't graded. Those are just for your study use. So those are just for study aids. So these are the objectives for the diabetes. We also talk about diabetes next semester in special needs, or next year, I should say, when you guys are seniors. We're going to talk about diabetes. So what I want you to remember, a lot of these topics, actually, cardiovascular disease, diabetes, lots of the things that we talk about this semester, we revisit for special needs. But the big thing that I try to do is talk more about the mechanism of the disease in this class, because it helps maybe understand the drugs a little bit better. And then when we're in special needs, we don't have to spend so much time re-lecturing diabetes. We can just breeze over it and then talk about actual patient care. Like, how are you going to treat a patient that has diabetes possibly differently than a patient that's healthy and doesn't have diabetes? So we can focus more on those aspects rather than going over all of these kind of mechanisms of the condition. So just some overview. These are some large numbers. We have sort of an epidemic of diabetes in this country. The last number that I got off the CDC was 34 million people with diabetes, 1 in 10, and then 1 in 5 don't know that they have it. So it's a pretty prevalent condition, and these comorbidities are what's attributing to things like, like COVID deaths in America are really a lot higher than in other countries. And we're supposed to be so advanced with our medicine, but we have a huge amount of people with comorbidities. We are not very healthy. Americans aren't generally very healthy, and unfortunately. And so that is a really big contributing factor. And so it's really important that we play our role as hygienists and try and educate our patients as best we can. And fortunately, some things actually specifically pertain to the mouth. So we have this wonderful in to talk to our patients about their health, their overall health, because diabetes and periodontal disease are so closely related. So we have this great kind of, entryway into a health conversation with our patients. So just some more facts. I'm not going to read all these. These are just kind of talking about how many people get diagnosed or who goes undiagnosed. And pre-diabetes, a ton of people in the country are pre-diabetic. So if people can recognize that they're pre-diabetic and do something about it before they turn into a full-fledged diabetic, and mostly we're talking about type 2 here, and we'll clarify that in a second. So it's a huge cost of diabetes in the United States, a huge amount of money toward medications and treatments and all the other negative cascading effects of other conditions that happen in the body when somebody has diabetes. So we want to kind of get a little bit to the kind of understand the core mechanism of what happens. So what happens when we eat? So we obviously eat food for energy. It's our fuel, and our bodies break it down into glucose. So glucose is our main, form of energy. Now, we don't need to eat sugar to make glucose. We can eat, whole grain bread and whole, brown rice and vegetables and things like that. And that will break down to glucose as well. It's just not nearly as fun as, a big chocolate cream pie. But that's what happens is the food we eat, we break down into glucose, and it gets into our bloodstream. And insulin is a hormone. So it's a hormone produced by the pancreas. And more specifically, it's secreted by these cells in the pancreas called beta cells of the islet of Langerhans. So that's a big old word. But if you can remember beta cells in the pancreas, that's going to be that's your key. That's what you need to remember. Beta cells in the pancreas. So our cells want glucose, but they can't get it out of the bloodstream unless insulin helps. So insulin is essentially like a lock and key. It unlocks the cells and it allows the cells to take up the glucose. So when the levels of glucose in the blood start to rise, your pancreas is alerted to release insulin. So it's sort of like low levels of glucose, your body's not doing much. Higher levels of glucose in the blood, your body goes, oh, I got to get some insulin. So then your pancreas releases it, and then it allows it to get into the cells. So the system is regulated by the body's needs in a healthy person. So like I already basically said, if your blood glucose spikes, then your body recognizes that and does accordingly with the insulin. Okay, so for individuals with diabetes, there's a couple different things that could be going wrong. So these are important. These 3 concepts are important for you guys to know for an exam. So, my goodness, hold on, sorry. So basically 3 things are happening with somebody who has diabetes. They either have too little insulin that's made in the body, or they don't make any. Usually when we're talking about type 1, they don't make any, or it's just too little. The liver is releasing too much glucose. So we have an excess of glucose released by the liver, or the cells have become desensitized to insulin and they can't use it. They're resistant to insulin and they can't use it well. So they might be making enough insulin, but their body just doesn't use it well. So those are the 3 things that you really want to know about those people with diabetes and what the 3 possible reasons why they are diabetic. Those are reasons why they're diabetic. Okay, so here's just another slide that pretty much says the same thing. Too little insulin or none at all, can't use it, or the liver has dumped too much glucose. So this again is just sort of a very busy slide, some slides from the CDC kind of showing levels. We talk about our A1Cs in clinic. You're going to actually be thinking a lot about your patient's A1C. This is a measurement of the hemoglobin. It's like a 3-month picture of a person's blood glucose level over a 3-month period of time. So it's a bigger snapshot. So if in general, they have a 6.5 or above A1C, then they're diabetic. If it's between this range, they're pre, and if it's below 5.7, they're normal. So then we can compare that to different kinds of glucose tests. There's the fasting blood glucose and the glucose tolerance. These are different types of tests that people may take. And so you can see how the numbers line up. But what's important about the A1C is that when you're in clinic, if your patient says to you, I'm diabetic and my A1C is 8, then you're going to take their blood glucose. And if their blood glucose that day is higher than 200, you can't see them. So these numbers are important for you to start to familiarize yourself with, so that when you're in clinic, you know what's allowed and what's not allowed. And then this is just showing how many people in the United States are pre-diabetic. So there's 2 types of diabetes. We have type 1, which is an autoimmune condition. So it's important for you to remember for the exam or a test that it's an autoimmune condition, type 1. And the pancreas makes too little insulin, or really what ends up happening, or like maybe when they're young, the beta cells are starting to die, but by the time they have full-fledged type 1 diabetes, typically they don't make any insulin. And then patients are therefore insulin dependent for the rest of their life. Type 2 diabetes is when generally enough insulin is being made, but the cells are not utilizing the insulin. So with this type of diabetes, the pancreas potentially could stop making insulin, because if it's just not working out and the body's just not doing what it's supposed to do, it could stop making insulin. But a lot of times it's just resistant and it's just not functioning appropriately. So type 2 usually comes on later in life. It's not autoimmune. It's lifestyle and genetic. There's a lot of genetic predispositions and lifestyle related. So individuals who have a family history, who are overweight, they tend to be susceptible to type 2 diabetes. And this is a video here. This is just a good overview of it. I won't play it, but you guys can click on it in the PowerPoint on your own time and watch it. So again, type 1 diabetes, autoimmune disease, 1 in 10 people with diabetes have type 1, so far fewer. So of those 35 million people that have diabetes, only 1 in 10 of those people have, so 10% have type 1 and 90% of those with diabetes have type 2. Most people are under the age of 20 when they're diagnosed, and the body can no longer make insulin. Hyperglycemia is a secondary to insulin deficiency. So what that's saying there is that in the beginning, the problem is you're not making insulin. That's the disease. That's the number one disease factor. But what's going to show that you have the disease and what's going to actually end up being the problem is the fact that you're just not going to be able to get glucose out of your bloodstream. And you're going to have, the patient's going to therefore have hyperglycemia. So that's why it says it's secondary to insulin deficiency, because that's sort of the effect of it. Insulin is not being produced as needed. I think we talked about that. 80 to 90% of beta cells have already been destroyed by the time these significant symptoms show up and somebody gets diagnosed. Symptoms of type 1, weight loss, loss of energy, increased thirst, increased frequency of urination, increased hunger, blurred vision. So a couple of things, there's a lot of these poly words. So polyphagia is increased appetite. Polyuria is increased urination. Polydipsia is increased thirst. Sometimes you'll see those things written down. You might see that like on a board exam. They'll say you have a patient, maybe there'll be a case study that talks about a patient with polyuria and polydipsia. What might you think this patient has, or what, it'll ask you something like that. So those terms are important to be familiar with. Let's see. Okay, so type 2 diabetes. So 90% of people with diabetes have type 2. It used to be called adult onset, where type 1 used to be called juvenile or early onset, but now it's just type 1, type 2. Most people are over the age of 40. Type 2 is becoming more common in children and teens, however. Type 2 is more likely affects people who are either chronically overweight, belong to certain ethnic groups, tend to have more diabetes in their population, or if there's a family history of type 2 diabetes. So those are some risk factors. This is just showing how through the years, the population of people with diabetes has grown, and you can see the little green figures are children. So in the 80s, between the 80s and 90s, it was really almost unheard of for kids to have type 2 diabetes. But now in our time, it's far more common, unfortunately. Diabetes is 2 to 4 times higher in minority populations, American Indians, African Americans, Hispanic Americans, and Asian Pacific Islanders. And educational levels affect rates of diagnosis. So the more people know about just diet and what foods to try to not to minimize and what to do to counterbalance these, then you can see the education goes a really long way. If a family, sometimes I remember when I was doing my undergraduate, I did a lot of research on Native Americans and the Native American populations that have very high rates of diabetes. And they almost seem imprisoned to their circumstances. Like the food on the shelves in the stores, especially like on reservations, it's almost like there's no other choice. There's lack of fresh fruits and vegetables, and it's not by their wanting it that way. It's almost like it's this horrible, imposed way of being. So there's not, you can educate somebody and they might have every desire to do that. But if the stores aren't, and so a lot of this stuff is federally funded foods and things like that. If the foods that are provided aren't fresh fruits and vegetables and whole grains and water, and instead that's, refined flours and soda pop, then, what else is to be expected? It can be very infuriating to do some public health research in some of these areas, especially specifically, I had looked at Native American populations because there is such a high level of diabetes. But anyways, it's very frustrating because, people, I think, would love to do different and eat different, especially if they had access or if things were more affordable, perhaps too. So you'll probably learn more about those topics in public health when you take public health as well. So type 2 diabetes is also, again, we have the same thing. Hyperglycemia is secondary to insulin resistance. And so it's basically saying the same thing. Your body's not utilizing the insulin. And so as a result of that, your secondary effect is the hyperglycemia. Insulin production is sufficient, but your cells aren't facilitating the use of the glucose entering the cells. Insulin resistance occurs when cells have a decreased sensitivity to insulin. And so, something about, I remember I've read and done some studies on, or, read articles about the lifestyle. And a lot of times people think, oh, it's, if you eat too much sugar, you're going to get type 2 diabetes. But there's a lot of interesting information out there about certain kinds of fats, the fat, they say good healthy fats and unhealthy fats, and there's and then these highly like refined processed like flours and things like that, and those actually can lead more to the cells being desensitized than necessarily just plain sugar, which sugar is not really good for you anyways. But there's a lot of really interesting information on that and how diet relates to causing this decreased sensitivity in the cells. Symptoms of type 2 diabetes. So I better check the time. Okay. Symptoms appear gradually for type 2 diabetes. And a lot of times people can have hyperglycemia. They can have high blood glucose for a long time and not realize that anything is actually amiss until they get to a certain level. And your body sort of adjusts and adapts to it. So you'll have people come into the clinic and you'll take their blood glucose and it'll be like 300. And they're like, oh, that's always my blood glucose. I feel fine. And you're just sitting there like, what? That's too high. That's bad. But it's because people's bodies sort of just become accustomed and adapt. That doesn't mean that damage is not occurring and that it's kind of like high blood pressure. It's the same thing. People can live with it and think they're fine, but really there's damage happening. So subtle symptoms or no symptoms in the early stages, then they start to have this increased thirst, increased urination, feeling tired. Symptoms may be mistaken for other situations or problems, aging, summer heat. So sometimes things get undiagnosed for a while, unless they specifically go and check their H1C or their blood glucose, do a fasting blood glucose. So long-term complications, basically, when you are in hyperglycemic condition, you're going to be over a long period of time. If this is a chronic state for your body to be hyperglycemic, then you're going to have damage to your blood vessels and nerves. So all these tiny little blood vessels, tiny little nerves, and that's why people have neuropathies. That's why you hear poor circulation, wounds that don't heal. It's all a cascading event from the damage that happens to tiny little blood vessels and nerves over the course of years of having hyperglycemia or being diabetic. And so people, in most severe cases, they have kidney problems and could go blind, have heart conditions. There's just a huge range of different things that can go wrong. Macrovascular complications can lead to coronary artery disease. So that's buildup of the plaques, if their triglyceride levels, they're bad. The LDL and the VLDL, we'll learn more about those, the small lipoproteins. And then we have the ones that carry out the cholesterol, the HDL. But when they're bad, or the cholesterol that you don't want is in high levels, and that causes that plaque buildup or that atherosclerosis in the heart. And so in the blood vessels in the heart. So people who have diabetes tend to have increased rates of atherosclerosis. And of course, this is going to lead, also, it's going to affect the circulation, but it can lead to heart attacks and stroke. So they're at much higher risk for all these other comorbidities when they're diabetic. This is just talking about the nerve damage. So we call it neuropathy, or the small blood vessel damage. The small blood vessel damage is what leads to things like the kidney disease and the blindness, because you just think of all the teeny tiny little blood vessels going into the back of your eye or into your kidneys. Your kidneys are full of blood vessels to help, filter out. They're our filtering system. And then, so of course, if that gets clogged and is not working as well, then you're not going to filter as well. And that's shows the kidney disease. And then, of course, you can also have numbness in the feet, the hands, poor circulation, and then other organs too, like stomach, bladders, and the sex organs can also be affected by nerve damage or neuropathy. And these are all with uncontrolled diabetes. So not being able to keep that blood glucose below a certain number for a long period of time. These are the long-term damaging effects. So how this relates to us, so dental disease or periodontal disease and diabetes, they have what's called a bidirectional relationship. So people who have difficulty maintaining their blood glucose tend to have more unstable periodontal disease, and people who have more unstable periodontal disease and who are diabetic tend to have a harder time controlling their blood glucose. So they found this bidirectional relationship, and it has a lot to do with the immune, the signaling that your body sends out when you have a chronic infection in your mouth, the periodontal disease. There's all kinds of immune modulators and different types of chemicals that are produced that are sent out in your bloodstream, and they also affect diabetes. So we have some little bits from different studies that I pulled. So people with diabetes have twice the risk of having periodontal disease, as well as increased risk of a dry mouth or fungal infection. They're just far less able to fight off infections. They're just immune compromised. People with poorly controlled diabetes, an A1C of 9 or above, are 3 times more likely to have severe periodontal disease. 1/3 of people with diabetes have severe periodontal disease with loss of attachment, measuring up to around 5 millimeters or more. And the role of periodontal inflammation is a major component in the pathogenesis of diabetes and the complications. So we just see this inner working between these two conditions. So it's so important for us to educate our patients about the importance of getting their mouths healthy and reducing the inflammation from periodontal disease to help them control their blood glucose and their diabetes, and vice versa. Avoid diabetes complication, keeping their blood glucose near as normal as possible. So when they're really proactive, checking their blood glucose, eating, more whole foods, more fruits and vegetables, making sure that they're consistent with their medications, all these things. And then of course, learning self-care skills, being active, taking walks, all of these things to help their body deal with and process glucose in a healthy way. Getting the support from the family and a healthcare team. If your whole family just wants to go out to eat every day and get fast food, but you're the one with the health consequences, you really need to get your family on board to help, taking medications as prescribed. people with diabetes can lead full and productive lives, obviously, especially if they're well maintained. If people keep their blood glucose in a target range, then there are all of these percentages as likely to decrease. So their, heart disease decreases by 42%, kidney disease decreases as much as 56, and on and on. So when they keep their blood glucose, so it's all about keeping that glucose in a normal range without having these major fluctuations. Same with type 2 diabetes. They decrease their risk of heart attack, eye damage, and kidney disease. So now we'll talk a little bit. Let me check the time. Okay, so we're going to talk about, so this is the guide for your clinical guide. This is in your handbook, your clinic manual. I bolded these things that are really important for you to know. 7% or less A1C with well-controlled diabetes, or 7.5 in elderly. If they have an A1C on record of 7 or below, and you take their blood glucose, it can be up to 250 milligrams per deciliter. But or that could be micrograms. I can't remember if it's milli or micro, whatever. But if there's no A1C, then they cannot be above 200, at or above 200. Anybody who's up to 300, they need to have an immediate referral to a physician if they're not under the care of one already. This is just a chart that shows how the A1C relates to a normal blood glucose range. And this just talks about regular physical activity and how it helps the patients. So good news about physical activity. Okay, so the medication. So if somebody's type 1 diabetes, they're just going to take insulin always for their entire life. There's no getting around it. There's no dietary fix. They are just going to have to be on insulin for the rest of their life. If they have type 2 diabetes, there's oral medications and insulin, or insulin alone. It just depends on what's happening specifically with them. So there's 3 main types of medications that are predominantly used in type 2 diabetes, and those are biguanides. So I'm going to come back to these. I just want to show you here. Biguanides are one. Sulfonylureas are a second. And insulin sensitizers are a third. So these are 3 different types of type 2 diabetes medications that you'll see. So with the biguanides, the mechanism of action is that it decreases glucose production from the liver. So it inhibits the liver from producing as much glucose. And the main one that you'll see all the time, and it's a top 20, is glucophage or metformin. A lot of times on the health history, you'll see metformin, but it's glucophage. Glucophage RX is extended release. There are also combination of pills that combine biguanides and sulfonylureas, or biguanides and insulin sensitizers. And that's these down here. So the metformin and the glipuride, or the glyburide, sorry, or the glipizide, or the rosiglitazone. Oh my goodness, this class is fun because all the medications are like tongue twisters. So these are all biguanides mixed with one of the other types. So biguanides have side effects of nausea, diarrhea, vomiting, sometimes weight loss. To decrease the side effects, they start with a low dose, taking with food, and then oftentimes the side effects will diminish over time. Then we have the sulfonylureas. These medications cause your pancreas to produce more insulin. So they're kicking out more insulin, which lowers blood glucose, of course. And then here's the different medications. A lot of times you'll see these generics, like I see in private practice, I used to see glipizide, and I don't know if I saw these 2 as much, but you might also see Amaryl and different, it depends. It can be written either way, but these are just some sulfonylureas. So biguanides decrease the liver production of glucose. Sulfonylureas increase insulin in the pancreas. So those are important notes to remember. Side effect of sulfonylurea, hypoglycemia. Now that's because if you increase insulin and the insulin's working and the cell is taking it up, it might take out too much glucose from the bloodstream, and then the patient could be hypoglycemic. So that's a side effect that needs to be cautioned. Or what if someone took their sulfonylurea drug, but they didn't eat and they don't have enough glucose in their bloodstream? Then they're going to be really hypoglycemic, right? So you have to think about those types of things. And then we have the insulin sensitizers. These drugs improve insulin sensitivity, helping cells use blood glucose for energy. So then we have this Avandia, Actos, or the generic names for these as well. And major side effects with the insulin sensitizers are fluid retention, weight gain, headaches, muscle pain, elevated liver enzymes. Liver should have liver function tests prior to taking the medication. So anything that affects liver enzymes, usually patients are tested fairly frequently to see how their liver is doing. And they should not take it if they have had a history of congestive heart failure. Probably obviously due to fluid retention. People who have congestive heart failure usually have poor circulation and retain fluid. So if this drug does that, then they don't want to give it to someone who has congestive heart failure. Increased chance of ovulation in menopausal women, and decreased effective of birth control. So women who are maybe just on that verge of thinking they're out of the ability to have kids, it could actually increase their chances of getting pregnant, even if they're sort of at that tail end. They think they're in menopause and it's not going to happen for them. It could. So that's something to be aware of. Insulin, you're not going to get tested on heavily on like different types of names and things like that for insulin. It's important to know that there's different speeds of action. So insulin can either be like rapidly like taken up and being effective very rapidly, or there's different short-term and long-term or intermediate term. So there's different ways that insulin can act in the body. So it's important to understand that, but you don't have to know like specific names. And of course, hypoglycemia, similarly with the sulfonylurea drugs, is going to be a major negative side effect. Someone gives themselves insulin, but they don't eat. That's a bad thing, because then they can go into hypoglycemia. Now, this is probably something that we'll talk about again, but one of the most common medical emergencies for a diabetic patient is not hyperglycemia. Now, people oftentimes think that they think, oh, diabetic, medical emergency, hyperglycemia. It's actually hypoglycemia, so low blood sugar. And that's because they've taken their medicine, but they haven't eaten, or they haven't eaten enough, or they're really anxious and they burned through their glucose, and they now they're hypoglycemic. So that's one thing. That's something you might find on a final exam or a national board, but a lot of times people go right to hyperglycemia, but it's actually hypoglycemia is what's they're most likely to have a medical emergency for. Because remember, hyperglycemia can be slow and they can build up a tolerance where they feel kind of normal. Even though negative things are happening in their body, they might feel like, oh, I'm okay. But hypoglycemia, you don't do well for very long if your body doesn't have blood glucose levels that it needs. So increased stress, illness increases glucose, emotional stress, carbohydrates, medications. What can decrease glucose is exercise and medication. So that's why people who have hyperglycemia were like, exercise and eat right. And that'll naturally, sometimes people can do it with lifestyle as opposed to just medications, or they start on low medications and see how it goes. But those are the things that affect blood glucose. This is the slide. We'll talk about this when we do our how to take our glucose reading. This is just a slide that shows the basic steps, but we'll do it together. What can you do if diabetes or uncontrolled diabetes? Check blood glucose. If at risk for diabetes or has diabetes, refer your patient to their physician or to a diabetic educator. Encourage patients to take care of their diabetes, to not ignore it, especially if it's in beginning stages, and then teach them about the relationship between periodontal disease and diabetes so that you have a really good kind of wedge into that conversation. And these are just some resources. So what time is it? Oh my gosh, 5 minutes. Okay, so that's it, you guys. I'm gonna give you a second here for if anyone has a question, and then we will, and then we'll close. And I will email you guys when the quiz is up on Moodle. And then I'll also be looking for an email that talks about when we'll gather next week, early next week, to do the blood glucose in the classroom. Okay. All right. That I think, oh, was there a question? Oh, technically class goes into, why did I think it went? I knew it went till 10:20 because that's when the speaker starts at 9:20 and that's an hour. Half of my brain isn't functioning well. Well, then I'm not going to rush. Do you guys have, if anyone has questions, but if not, then you get 25 minutes to go get coffee or tea, drink water, do something healthy. All right. Okay. We're going to end then. Thanks, guys. Thanks for putting up with me. I apologize for this. And I will talk to you later. Okay.